Okay, so topics, we're going to talk about 4 different things today. So diabetic emergencies, cold weather emergencies, consent, and restraints. So diabetic emergencies, we're really going to be talking about hypoglycemia, and just with the new D10 protocol, just kind of wanted to go through like kind of when to use D10 as opposed to like oral glucose and glucagon. And so, definition, hypoglycemia is blood sugar less than 60. Etiology, typically it's from with diabetic patients, although some patients that are not diabetic can be hypoglycemic as well. And so, sepsis is a common cause of hypoglycemia. Alcohol, people that are drinking a lot of alcohol can become hypoglycemic. Cardiac renal failure, cortisol deficiencies, and an insulin secreting tumor as well, called an insulinoma, can cause hypoglycemia. And so typically the medications that you would see with it, obviously insulin's the most common. Sulfonylureas, like medications like glimepiride, are very important to know because they're very potent hypoglycemic medications. And actually, as you bring their blood sugar up, they can have like a rebound hypoglycemia again. So those patients are important to kind of get an accurate med list. And then some of the other, can't even pronounce that drug class, but the pioglitazone medications are other ones that can cause hypoglycemia. Medications like metformin and things like that don't typically cause hypoglycemia, so that's not necessarily one that you need to worry about in patients, diabetic patients. So symptoms, we've all seen this. So they're going to be altered. So they can either be like lethargic or somnolent, or really agitated and combative. They can, have coma-like syndromes, even stroke-like symptoms. So, a lot of times if you have patients that are, presenting and you're concerned for a stroke, that's obviously one of the things that we want to check right away is a blood sugar, so that we can kind of replace the sugar if it's too low. And then continue down, if they don't improve, continue down the stroke pathway. So, and then obviously skin is pale and diaphoretic. Management, so initially, obviously with any patient, you kind of go in and ABCs, to obtain a set of vital signs. And then, if the patient is awake and talking to you, but just kind of confused, obviously, least invasive method possible. So just go ahead and give them some oral glucose to try to get their blood sugar up. And then after you give them like the oral glucose, then, have them eat. So, complex carbs, protein, that sort of stuff. If they are unresponsive, we can attempt IV access. And so, I would say try to give it, if they're unresponsive, give it one attempt. If you get the IV, that's great. You can go ahead and start administering the D10 solution. And typically 100 mLs is what the initial bolus is. So it typically comes in like a 500 ml bag. You give 100 mLs, and then you wait to see if there's any sort of response. And so you give it about 2 to 5 minutes, reassess. And then if you don't get any response after those 100 mLs, you can do another 50 mLs of the D10.
How long do you want us to give that 100 over?
So they don't have a great, so you just kind of bolus it in. So it's not like over a specific period of time. So just kind of bolus it in. Obviously make sure the IV is secured, because the sugar solution can be like necrotic to the tissue, so it can be very irritating. So you want to make sure it's a good solid IV and it didn't blow. But yeah, just bolusing and it should be fine. And so after the, if you get the IV, you give the D10, and then once you get the blood sugar up, they should improve clinically too. So they should wake up, or they should become less combative, et cetera. And then, afterwards, then you feed them, because the blood sugar, that's just going to spike their blood sugar up. But you need to make sure you get something in there that will help to keep that blood sugar elevated. That's one of the complications that we even see, like with WASP bringing the patients in. So they give them the 100 mLs of the D10, and by the time they get to us, it just drops right back down again. And then we have to give them another bolus, and then give them some food and have them eat afterwards. So especially with you guys with a longer transport time. going to be multiple, or is that just the one? That's okay. All right, perfect. Okay. So that's one of the complications that we've seen with WAS, and so typically we would be giving like the D50, so the really concentrated solution, and that would spike their blood sugar up really high, and so we've kind of in the ER as well as EMS have moved to the D10. It's a little bit safer if the IV does blow than the D50. Plus, it doesn't spike their blood sugar up too high. But what we have seen is that if we don't feed them right away, then that blood sugar kind of drops back down. So especially since we're going to have longer transport times coming from Rushford up, it's like trying to make sure as you're getting their blood sugar up, grab some food or something on the way out of the house just so that they have something to eat in the back of the ambulance.
Something with protein, right?
Yeah, so something like complex carb and protein, something like that. So that it's a little bit more complex and it takes a little bit longer for the body to break it down. So. And then if, obviously if the IV is unsuccessful after that one attempt, then, just a protocol the way it was before, so just the IM dose of glucagon. Any other questions about the D10 and the IV and stuff?
Glucagon won't release anything that you've administered with this D10, right?
Correct, yeah.
Okay, that's what I thought. I just want to make sure.
Yeah.
So we can't get any additional boost
Right.
by using glucagon if they crash hard
Right.
after an IV.
Right.
IV is the last.
Yep. Yeah. IV is getting the sugar kind of right into the bloodstream. That's kind of the best the fastest way to get the blood sugar up. So.
What is your parameters or is it just going to be clinically based on symptoms?
Clinically on symptoms. So I mean, if someone's awake and talking to you, but their blood sugar is low, then I would just give them oral. If they are, but if they become unresponsive. Now, okay, so I guess there is some caveats, right? So we've had a lady in Winona whose blood sugar routinely drops down to like 30 or 20 or something, and by some grace of God, she's still awake and talking. So in that instance, it's okay to start an IV and do the D10, but obviously try the oral glucose as well, just since she's awake and talking, because as we're fumbling around with an IV, it obviously takes time for anybody to start an IV. So so give them the oral glucose while you're trying to get IV access in that patient. If it's extremely low, anticipating that they might become unresponsive, then
What about giving glucagon to get them out of the house?
You certainly could do that too.
Okay,
So
we
yeah,
can
yeah.
hit glucagon and then start
Yep.
the IV once
And
we're in the
absolutely, yeah.
We're just whispering that you're trying to.
Yeah, absolutely. No, don't whisper. Ask the questions right away. Yeah, I don't mind.
95% of the time after we give them the glucagon, they're awake, and then they don't want to go anywhere anyhow.
Yeah, yeah. So that's a good thing with the disposition for these patients, right? So most patients should be transported. A lot of times they do want to refuse. It's important to kind of go through their medications and stuff too and try to see exactly what happened. Because if it's just like, they took their insulin before having lunch and like didn't sit down to actually eat lunch and got sidetracked, then okay, that's fine. It's a short-acting insulin. You give them the whatever to kind of get their blood sugar up, and then you have them eat. That should be fine. But if they're on one of those like sulfonylureas, or if they like took their too much of their like long-acting insulin or something along those lines, those are the patients that you really are concerned that they're going to just kind of bottom out again, and they're not going to be able to keep their blood sugar up. Criteria that we typically talk about for people refusing, obviously they need to be able to be awake and alert and be able to make their own decisions, have capacity to make their own decisions. But then also if they have someone around, that's like I feel a lot better about people refusing if there's someone else there that can intervene or call 911 if they need to again, making sure that they kind of understand exactly what happened. If it was like, well, I don't know what the heck happened, my blood sugar was low. Those are ones that are a little bit less comfortable with them signing off. Now, if they have the ability to make their own decisions, you explain to them like, hey, I'm worried, I'm not sure exactly what caused your blood sugar to be low. Why don't we bring you over to the ER, have them watch you for a little bit, check some things out, and then they'll be able to get you going home later today or whatever. If you explain all that to them and they still say, screw you, I don't want to do this, then you can't kidnap them and force them to go if they're awake and alert. So.
What about if they refuse after we start the IV? Right, we get that
So after you,
first shot into them.
Yeah.
They feel a lot better after we, give them the first 100 milliliters, and then they refuse.
Yeah, so if they refuse, it's kind of same thing. If they had the ability to refuse and stuff, then you just, take the IV out and, go over risks and benefits. And, this could potentially, we gave you the sugar to get your blood sugar up, but it could potentially come back. It could be, worsening again. And you could, I always scare people with like the worst case, right? Because you want to say you could die, right? If your blood sugar drops down too low and no one's there, you could die from this. And that's not just trying to be a jerk. It's, true. And so if they understand that, and they have someone there, then I think that's fine. And yeah, if they have the IV, just pull the IV out. That's
And when
fine.
you say long acting, you mean like a NPH or a 70/30 or?
Yeah, so one of those, or like Lantus or Levemir, they typically take them at night most of the time. So like it's or the NPH or the 70/30, they take typically twice a day. And so if they're on one of those, or if they took the long-acting Lantus or Levemir, then those are ones more concerning that they should probably come in.
Some of those big words you're saying right now, we might not all know, Joey.
So
They're just specific
okay.
brands or trade names of different insulins that are out there.
Yeah, so the 70/30 is a mixture of a percentage, I forget which percentage is which. I think the 70% is the short acting and the 30% is the long acting, where it's a mixture of the short acting and long acting. And so it was, they originally started using it for ease of administration because people wouldn't want to have to take a different insulin at bedtime for their basal so that keeps their blood sugar under control, and then take insulin with short-acting insulin with meals. So they did this 70/30 combination that they would take kind of twice a day. So it was more ease of administration, but you would get more like hypoglycemic episodes with it because it wouldn't be timed well with like meals and stuff. I don't know if you guys have many people in the community here using that. I don't know that I see a lot of people on the 70/30 anymore. That was a couple years ago. Yeah.
What are the pumps running?
What's that?
What are the pumps running?
Just the short acting. Yeah, so the pumps run a short acting, and the pumps run it at like a basal rate, and then just you can kind of bolus it off of the pump to give you that meal coverage as well.
Because we do have a gentleman in town, hasn't been lately, but he's got a history of crashing pretty hard. I think, wasn't his pump faulty or something?
No, he just didn't brain.
Yeah, he just
Oh.
didn't. Yeah.
But
Or 100 miles an hour and not eat. And then
Yeah.
gummy bears when he did, and then was crashed.
yeah,
Lowest I saw
so
him at was 16.
And we got a lady out in Town that's on the long and the short,
Yep.
and she'll mix them up once in a while.
Yeah, that's dangerous.
She does that, she goes.
Yeah.
She just crashes.
Yeah, so if they mix them up, if they've taken like a long acting with a meal, then they're going to crash hard, and they're going to need like a dextro, like a sugar drip in the hospital. So it's like a long, that would be more of like a longer hospitalization. Yeah, so that's where it's important to kind of know what's going on or know what.
We don't-
Is there any interaction between D10 and the pumps, where it's constant monitoring? Turn their pumps off at that point? Or?
Yeah. So I mean, if you're going to administer, then just kind of turn the pumps off. They should have, most of the time, if they have the pumps, they have that continuous glucose monitor as well. So it'd be kind of alerting, and you have a better idea of like kind of the progress you're making with that. But
With the new ones that inject into the arm and they keep it on for like a week,
mhm.
what?
The monitors or the
well,
the Dexcom.
Yeah,
Mhm.
yes.
Mhm.
Do you see any issues that we would run into with those? Like, what do we do, or why would they
That's
even?
a monitor.
That's, there's no insulin in that.
There's not.
That's
Should that
strictly,
just send it to their phone? Or
Yep.
how does
it's an app you can use on their phone, or they can have a meter itself from the company, but it's strictly just a blood sugar machine monitor.
Okay.
So that's a really good thing too, because we're seeing a lot of these in the community, and they're very beneficial. They're very helpful. The other thing too is if you have someone that clinically looks like their blood sugar is low and the Dexcom is reading it's normal, it's always worth just doing a quick finger stick and checking it yourself, because those can sometimes be a little faulty. So it's worth it just to kind of check, just to be sure. But yeah, those are really really handy to have. So
If the patient hasn't changed the meter in a while, past when it was supposed to have been done, can that give you a faulty reading?
yeah. So they need to make sure they're changing it every 7 days or week, or I think it is something like that. But if it's on too long or something like that, then yeah, you you can't really trust the readings as well. So,
Good to know.
and when in doubt, just do a quick finger stick yourself, just to kind of get another.
It's automatic thing, we just should, no
point.
matter what.
Right.
Yeah.
Well, for a while, it was our protocol before going into
Yes.
Winona.
Yeah,
And then
yes.
all the ERs picked it up. That was probably 10 years ago they started that.
Yeah.
They all wanted a blood sugar.
Yeah.
Okay, good.
Yep.
Yep, pretty much, yeah.
All the people.
Not the religious patients.
Not the crew people, yeah.
And you guys are still running that on incoming, right?
Yeah.
Perfect.
Any other hypoglycemia D10 questions before we move on to the next?
Is there any ages around D10 or not? We give it to,
You can give it to any. Yeah, you can give it to children. Children, it's I didn't put that in here. It's a 0. It's a 5 ml per kg, 5 milliliter per kilogram. Up to the 100 then. So once I get to that.
Age-wise.
So that's up until, well, so that's any age up until they are like what? It would be the 20 kilos, so that they would get, then that would be the 100. So that's any age, even adults too, if they're less than 20 kilos for some reason. You can give them that's the weight-based dose for it.
Okay.
And so that's just up to the to the 20 kilos then.
So that's around 50 pounds, a little less than 50 pounds. So,
Yeah. So then, if teenagers, that we would most likely be giving just the full 100 ml. We should probably put that into the protocol then,
yeah.
if it's not in the protocol. I didn't see that. Good question though.
I'll make myself a note.
Thank you.
Is there any interaction between alcohol intoxication with hypoglycemia?
I mean, it's just very common. I mean, you'd see that in people that are drinking a lot of alcohol. So, I mean, it's just something to be aware of, not necessarily anything different in terms of management with it, but it's just, they go kind of close together, or they're commonly associated.
but I mean, there's nothing in that that would be considered a common allergy that you have to mention. Is there in that D10 that we have to worry about?
No,
No
No.
indicators.
no. Unless they had an allergic reaction to D10 in the past, which would be very interesting. Okay, we'll move on to cold weather emergencies. So first we'll talk about kind of more localized cold injuries. That would include frostbite, frost nip, trench foot, and chilblains. And then more kind of global, which is hypothermia. The localized injuries, freezing injuries, obviously we've all heard of, frostbite. It's a severe localized cold injury due to freezing of the tissue and causes pretty significant tissue destruction. Frost nip, I think everybody in Minnesota has probably had this at one point in their life. It's just this localized sort of cold-induced like paresthesia. So if you've been out in the cold too long and your fingertips get kind of numb and tingly, and then it just resolves when you kind of go inside and kind of warm your hands up and everything. That's frost nip. That's the fancy name for it. Yep, yeah, it's stinging, burning, pins and needle things. Yep. And so obviously there's no long-term tissue destruction. There's no long-term damage with that or complications. Trench foot, it's, kind of from the, you see it a lot in the military, but people, if they're, homeless or things like that as well, or they don't have good, hygiene, it comes from a kind of prolonged cold, like wet exposure basically in their feet. Chilblains is just localized inflammatory lesions on the extremities. It kind of occurs from like repetitive cold exposures, and those symptoms generally are self-limiting and kind of resolve within 1 to 2 weeks. So we'll start at the bottom, work our way up. So starting with the chilblains, it's at local inflammatory lesions, and these are the kind of lesions that you see. So you can kind of see On the left hand, on the fingers there, you see kind of some pale, kind of red lesions, and then on the right hand, on the index finger there, you see kind of a darker lesion. And so these are just those local inflammatory lesions. Most of the time they appear on the hands, the legs, the feet, and they can start to appear about 12 hours after injury. So this isn't going to be someone that you kind of pull out of a snowbank where you're going to see this. This is someone that was like, the next, they're going to wake up in the morning and they're going to be like, what the heck are these things on my hands? They were out in, the snow or something, the night before. Typically, you feel more like kind of numb and tingly. They're going to have like that numbness in their hands. And for whatever reason, I didn't really understand why, but it's typically more in women and children. So, and treatment with this, there's nothing really special with it. It's just more rewarming. So nothing else that more significant. Trench foot is a non-freezing injury. It's just more from the prolonged cooling and submersion in wet conditions. Clinically, they'll have kind of numbness, tingling, which a lot of these cold injuries have. And the skin, as you can see there, is kind of pale. You can sometimes see some mottling or that kind of lacy appearance on the skin. You can actually, not have pulses and not be able to like kind of move the foot or the ankle. And so obviously treatment with this, if you have someone with trench foot, you kind of don't want to have them walk or put weight on the foot. So you kind of want to, get them to the ambulance and kind of warm them up. Once you get them in the ambulance, then you can remove the cold, wet clothing, dry them off, and apply warm blankets and transport them to the ER. And then management. There's kind of a lot of delayed injuries and stuff like that with this, with rewarming. But for the EMS side of things, it's just kind of getting them out of the cold, wet stuff once they're in the warm ambulance, and just warm blankets and just transporting them in. Any questions about those two? Those are just not significant. Yeah. I mean, sometimes it can be numb and tingling. Once it starts to rewarm, then it starts to become painful. So that's one of the things they talk about too. Is that might be one that they're fine initially when you start transporting them, and then as they're starting to warm up, they can have like a lot of pain. And so that may be something they may need like an intercept for pain management, because I understand it's very, very painful. So. Might need like IV and narcotics and stuff like that. So that would be one to potentially start an IV on too. But if they have a lot of pain, if they're like writhing in pain and need something to kind of help control before you get there. If they're comfortable, or they're comfortable enough and like not too in too much pain, that you can just kind of transport them. So. And so the next, and this is one we'll spend a bit more time on because it's a little bit more kind of going on. So frostbite. Frostbite is the freezing of the tissue, and you can have kind of two injuries with it. One is the immediate cell death that occurs when the skin and the tissue freezes, and then you have this like delayed inflammatory response when you have reperfusion, or when you start to rewarm the tissue again. Just common times that they kind of quote for risk of frostbite in the kind of ambient air. If it's like 0 degrees and you have exposed skin, you can start to develop frostbite within 30 minutes. And at -15, within 15 minutes, you can start to develop frostbite. Most commonly, we'll be kind of on more high alert, or more considering it in the community when the temperatures are less than 20 degrees Fahrenheit. And so there's lots of things that kind of go into it as well. So the National Weather, or the NOAA, whatever that group is, they put out this chart with kind of the temperature and the wind chill, and with how long you would have to be outside to get frostbite. The wind chill plays a significant factor in it as well. So not only just the temperature in the air, but the wind chill as well. So risk factors. You know, some alcohol, drugs. So if people are impaired in their cognition and they're now, you know, they won't necessarily feel, and they can, you know, be more prone to frostbite. Smoking, because of the peripheral vascular disease associated with it, because your blood vessels get kind of more clamped down peripherally, you're at a little bit increased risk of developing frostbite. Obviously, inappropriate clothing, not wearing gloves or, you know, boots and things like that, and other conditions. So vascular disease, peripheral vascular disease, Raynaud's, which is this kind of phenomenon in your hands where like you have this vasoconstriction where the blood vessels kind of constrict, and it's very patriotic because your fingers can turn red, white, or blue depending on, you know, what's going on in your hands. So. But they have decreased blood flow to the fingers, and so they're more prone to getting frostbite as well. Diabetes, again, because of the vascular complications. The temperature and the wind chill we talked about are, you know, risk factors, so those are more environmental, altitude, and the wetness too. So like if it's just like dry and cold, that's one thing, as opposed to if they're like kind of had their hand in the snow or holding on to like a metal object, like a metal like flagpole or something like that, where you have that kind of transmission of the cold to the skin. It's a little bit less timing to develop frost. Clinical features. There's some. We'll go. You know, gotta have some good pictures, gory pictures in this part. So.
Is that real? That
Yeah.
bottom one?
Yeah. So that's
Wow.
kind of
It's just like
delayed. So clinical features. I was kind of surprised that when I was looking and like researching for this, most commonly it's you get frostbite on the face. So on the head. So it's ears, nose, cheeks, chin. Most commonly 31 to 39% based on this site that I was looking at. Hands are next most common, which kind of understandably, and then feet. And so initially, when we see them, if we kind of pull them out, or we kind of, they're complaining of pain or numbness, their extremity is going to be cold. It's going to be like ataxic or kind of clumsy, so you're not going to be able to kind of like move your fingers with the same dexterity that you normally have. They're going to feel kind of clumsy, or your toes aren't going to be able to kind of work the way they normally do. Initially, you're going to have the appearance of the top left, where you can kind of see it's, kind of a little pale or like a grayish color, and it's like the skin is like kind of cold and it's hard and like waxy feeling. Initially, if you pull them kind of right out of the cold, you're not going to see like the blisters or things like that. The blisters start to form as you're starting to rewarm, and you get that, blood flow, and you get all of that inflammatory response, and you'll start to get some of the blisters forming. And then that like black eschar kind of forms within like days to like a week or so. And so that bottom right picture is not going to be someone that you directly like pull out of a snowbank, but that's going to be someone that it's like kind of more delayed. So if they, were out in the cold and then they had, these symptoms and they stayed at home, which we see occasionally, and then they, come in and like a week later and their foot looks like that or their hands look like that. So that's more of a delayed presentation.
Is the top photo treatable?
Yeah. So the top photo is treatable depending on, and we'll go over kind of classifications and things like that. Depending on how extensive or how deep the frostbite is, it really depends on what the end result is going to be. And so, if it gets too deep, then they will have to have amputations. If it's more just superficial, then it's you can kind of rewarm and have less long-term kind of sequelae. So there's two different classifications, and so we'll go through this one first. This is the first, second, third, and fourth degree. This is the most common, or like the typical classification. And so it's similar to burns. And you're going from like superficial to deep, right? So first degree is more superficial. It's like, the sunburn. And so with superficial or first degree frostbite, it's you have just the kind of pale appearance to the skin. It's cold. You have that numbness. but typically you don't get like the blisters forming with it, and you don't have that long-term sequelae. You're not going to need amputations or things like that. It's going to be something that, you know, we rewarm and they end up doing okay and not ended up with kind of long-term morbidity from it. Second degree is where you're starting to get a little bit deeper into the tissues. You can see, I don't know if it projects very well, but the top picture is showing a second degree where it has those blisters. And typically, so with the second degree, you'll see the blisters are more clear. And so they'll be just sort of clear or like mildly like yellow appearing sort of fluid in the blister. Typically with those, if they're kind of small, you won't always lose tissue, so you won't always have to amputate with second degree. Once you get into third degree, that's kind of deeper. It's getting down into the deeper soft tissue. You're getting more hemorrhagic blisters, which are like kind of the blood-filled kind of blisters. And those eventually turn into these black eschars, and will need some amputation most of the time to kind of take off some of the tissue. And then fourth degree is kind of when it gets down into like the muscle and the bone, and that's more complete destruction of the tissue. And so then you're going to get mummification in a couple of, in like 7 to 10 days, it was saying. So, and those will need obviously amputation as well. So that's a more classic sort of classification of frostbite. They have this kind of newer classification where it's basically, where it's more for like extremities. And so I love that the site I was using had black and white for like, as they're describing colored images, like that's great, right? So it's grade 1 through 4. And so again, it's similar in terms of the goal for this was to kind of figure out early on which patients are going to be more likely to have to need amputation or some sort of more aggressive intervention. And so basically it looks at the kind of extent of the lesion. So grade 1, typically it's more just kind of like pale appearing on the fingertips. Maybe you can have some like blue appearing or cyanosis on the fingertips, but it doesn't progress past the fingertips. And that is very good in terms of the clinical outcome with that. So you'd have no, you don't need any amputations. It's rewarmed. It ends up, having recovery. It's kind of similar to that, like superficial on the other classification. Grade 2, it's once they get to that distal phalanx, so like the joint here at the end of the finger or the toe. Once it kind of gets down to that part of the finger or the toe, then you sometimes will have to have just like the soft tissue kind of removed of the finger, not necessarily have to like take off, lop the bone off or anything. Third degree is kind of when it goes down to that's the picture on the bottom left there, so you can kind of see where it's kind of at that PIP or this joint in here on the finger. And so that one, you're going to be, if you have the kind of skin changes and the blistering forming there, then you're going to have have amputation of pretty much the finger down to the level of where it's at. So whether it's at that joint or just above or just below. And once it gets down kind of into the hand, then it's going to be more, kind of losing part of your hand then as well. And so it's just different classification. It's not super important for what we're kind of doing. It's, just knowing that the further, kind of down the hand or that further up the foot or whatever it is, or the more kind of blistering or things like that you see, the worse it is. They definitely need to come in and be seen. But don't get too reassured if you just see that kind of like pale sort of appearance, because sometimes the blisters can take, hours to form, up to like 12 hours or so. So anyone that has that cold exposure and they have that like pale bluish color skin, they're really numb and tingling, and it feels that kind of, waxy feeling. That's someone to bring to the ER to have them evaluated, or recommend they go to the ER. So
if they are refusing to be treated or have somebody take them in, so a case like 3 or 4, that can lead to gangrene, correct?
Yeah, yeah. So, those people you say, hey, you're probably, it's very likely that you're going to lose part of your fingers or your hand. If you don't get it treated, you can get infected and become septic and die. And so it always comes to death, right? When you're trying to get people to go in and die, and you will die. But it's a good, it's one of those medical legal things where if they refuse and they have this really bad outcome and they eventually end up dying, and well, they never told me that it could be this bad. I thought it was just going to be a little rash. It's better to kind of overcommit to it than undercommit. So if you over exaggerate, and it's not like you're kind of making it up. It's actually plausible that can happen. You can become septic, and sepsis, routinely does, kind of have a higher morbidity with it or mortality. So, yeah. And so you need to make sure they're aware of the worst case scenario. And most of the time, we have had people refuse, and then they come in a week or so later, and then they have the appearance where their fingers look like that and they're black, And so, as long as they, kind of understand, again, it's one of those that you can't force people to do it. So
And document that, we educate.
absolutely, yeah. So documentation is very important. So documenting that, yes, So we'll talk about this a little bit in the consent part of it, but yeah, absolutely. So documenting that you explain the risks and benefits. These are the risks that I explained to them. This is what potentially can happen. They are, alert and oriented. They seem to understand what I'm telling them, and they have the ability to make their own decisions. They're not intoxicated. They're not high. They're not, hypoglycemic or things like that. They have all their faculties there that they can make these decisions, and they're able to repeat back to me what I said, so that I know that they understood me. So, and we can talk a little bit more about that consent piece, in the consent piece, because that's very important when we're kind of documenting the refusals and stuff. So the management part of this. So same thing with the trench foot. We don't want them to walk on it if it's on their feet, so obviously get them up, onto the cot, get them, into the ambulance. Warm them up. You want to remove the wet clothing, and then put them in wrap them, warm blanket. You want to try to avoid refreezing, so try to make sure you keep the ambulance nice and warm. We're going to be sweating in the back, and there's splint. Sometimes they're in a lot of pain with kind of movement of the extremity. So just kind of splinting or just padding, just kind of propping some blankets and pillows and that sort of stuff to splint it. You don't necessarily need to pull out a SAM splint or something like that unless you feel like it's absolutely necessary. And it's common, when someone's cold, you kind of do this to rub. Don't rub the hand or the foot or something like that with frostbite. Just kind of try to put the warm blankets and stuff.
Probably won't let you put the blanket on them either.
That's true. Yes. Yeah.
Or the rewarming packs, that would be too much too fast.
Yeah. So you want to kind of just more passively rewarm it with the warm blankets in the warm truck and that sort of stuff. You don't want to necessarily put the heat packs and stuff like that in them. So. Any other discussion about frostbite before we move on to hypothermia?
So, is it true that if tissue freezes, it crystallizes,
Mm-hmm.
and then it cuts?
It cuts.
Well, it freezes because it expands?
Yeah,
crystallizes,
yep.
it cuts the tissue?
Yeah, so you will get vascular injury with that, and then that's when you kind of rewarm. That's when the blisters and everything like that starts to form. So if it's deep into that second degree, where it kind of gets down, and when you start to rewarm, that's where you get the blood-filled blisters, because you have that injury to the blood vessels there. So you're leaking the blood into those blisters. And the superficial, it's not quite down to where you're getting enough of the blood vessels, so that's where you're getting more of just that inflammatory fluid into the blisters, and it's more clear. So yeah, there is that kind of crystallization and that destruction with it crystallizing. So. Anything else before we move on? Okay. So hypothermia. Hypothermia is split up into 3 different categories: mild, moderate, and severe. So mild is anywhere from 90 to 95 degrees, moderate is 82 to 90, and severe is less than 82. And so that's just the definitions, and it kind of correlates clinically with kind of how they're doing. Etiology, there's either kind of immersions or not immersions. So, someone in like a cold, river, like cold creek, versus someone just kind of out, passed out drunk outside, the risk factors for hypothermia are very similar to the risk factors for frostbite. So it's going to be, kind of the alcohol, the drugs, and all of the other things that we were kind of talking about. You're a little bit more kind of concerned with the elderly in hypothermia as well, for a lot of different reasons, the frailer skin, things like that. And so you just, elderly with frostbite, you're just a little bit more concerned about. So physical exam. So the physical exam is variable depending on the degree of hypothermia. So for mild hypothermia, and again, that's that like kind of 90 to 95 range, your vitals, you'll see they'll be tachypnic, so they'll be breathing quickly. They'll be tachycardic, so their heart rate will be beating quickly. And then they'll appear very like kind of almost like they're drunk. So like clumsy, slurred speech, they'll be shivering and just seem kind of, a little out of it. So moderate, and that's when you get to that like 82 to 90 degrees. So that actually, they're going to be bradycardic, so their heart rate's actually going to be slower, and they're going to be hypotensive, and then they're going to be like breathing a lot slower. And so that's one of those where if their temperature is down lower, like less than 90, between 82 and 90, and they are tachycardic, that's when we need to be concerned something else is going on. Are they dehydrated as well? Are they hypoglycemic? Is there some other like intoxication or something else kind of happening here? Because typically at that kind of moderate range, everything should be kind of slowed. So their heart rate should be slowed, their blood pressure should be low, they should not be breathing quickly. They're going to be very lethargic, so sometimes they're going to be really somnolent, difficult to arouse. At that point, when your body temperature gets that low, you don't really shiver anymore, so you won't be shivering. And those are ones that's where you start to get concerned about their airway, with them being kind of really lethargic and sleepy. That's one to consider, EMS or ALS intercept or, eye gel if they're really, not controlling their airway. And then that severe or that temperature less than 82, they're going to be hypotensive and cardiovascular collapse. That's where you're going to start, people where you're going to have to start coding them, and so they're going to be comatose. And again, there's no shivering on exam. So a couple of things with just in general with handling and kind of management of hypothermia. So these patients, you do want to handle them gently, very sort of rigorous or, kind of hitting, bumps and stuff like that as you're moving, not to kind of terrify people, but certain vigorous sort of movement of the patient or things can actually precipitate arrhythmias, and VFib being a common arrhythmia in someone that is hypothermic. So you just want to be careful with kind of moving, patients around. Obviously, you want to remove them from the environment, get them into the ambulance, remove the wet clothing, dry them off. This is an instance where I would say, especially if they're in the moderate range, but even the mild range, I would say, starting an IV for some warm fluids would not be the wrong thing to do. Definitely if they're at the moderate to severe range, absolutely you want to get an IV. By the book, the mild, they say, just the passive rewarming. So the warm packs, the warm blankets, that sort of stuff should be fine. If they come into the ER and they're anywhere from 90 to 95 and putting an IV, giving them warm fluids, no one's going to fault you for doing that. So I think that would be fine. But yeah, just want to try to just be careful with the patients. So talking about cardiac arrest, so there's a couple of differences for hypothermic cardiac arrest. So mainly, some of our, drugs and medications and shocks and things like that don't work when people are too cold. And so initially what you want to do too, so initially when we, go and there's an unresponsive patient, we have low threshold to start CPR. If we see that they're not breathing, we don't feel a pulse for 10 seconds, then we start CPR. Since they are so sensitive to being kind of jostled, and obviously CPR is very aggressive and violent, the recommendations are actually to not start CPR for up to a minute. So take a full 30 seconds to 60 seconds to feel for a pulse, to look for any respirations before starting CPR, because if someone is just really hypotensive and you're just having a difficult time feeling the pulse, or if they're just really kind of somnolent and you're just, not taking the time to feel for that pulse, you can do more damage by doing the CPR than good. So it's one of those that it's really hard, because everything about us is wanting to just go in there and jump on the chest and start, doing CPR right away. But just take a little bit extra time just to feel for that pulse, just to make sure that you don't have a pulse before starting CPR in these patients. Because whereas someone that is completely normal body temperature and we start CPR and it was just like they just passed out and they just had a low blood pressure, and we do a couple of compressions and then they kind of wake up and they're good, no harm, no foul. This person, if like they had a pulse and they were just really hypotensive, when we start compressions, we can precipitate, VFib in them. So
How low could their heart rate possibly be?
yeah, so like down in like 30s and stuff like that, you would kind of you would see. And I mean, if their blood pressure or if their heart rate is in the 30s and their blood pressure is, too low to be detected, then at that point you would end up doing CPR anyway and just kind of treating them as a cardiac arrest.
So is this like an immersion episode?
So any hypothermic patient that is unresponsive. So if they are cold and they're like in that moderate to severe, to severe range where they're like that less than 82. That's where, those are the ones that are going to be more likely to have cardiac arrest. And so these are the ones that are going to be bradycardic and hypotensive anyway. So that's why they recommend taking the extra time to kind of feel for the pulse.
And not dead till they're warm.
Exactly, yep. So that was so you cannot call the code until their temperature is at least greater than 86. Because, so there's a lot of our like drugs that don't work when their temperature's that low, so like atropine, epi, things like that. They don't work when the temperature's kind of down in the 80s. Even the shocks don't really work, and so you need to warm them up. And so these are ones where most of the time we transport and we get them to a hospital. Mayo Clinic has the ability to do ECMO, which is extracorporeal membrane oxygenation, something like that. But so basically, it's where it's basically like they pull your blood out of your system. They kind of run it through something that oxygenates it, warms it, and puts it back into your system. And so this is an indication for cardiac arrest in a hypothermic patient, where they would put somebody on ECMO in the emergency department and kind of do it.
So are we transporting those people right to Mayo then?
I would say that would probably be the best.
Or
You would
flying.
get them, yeah. So I would say you would get the best outcome by getting someone to Mayo. So calling for a helicopter,
Will they fly
trying to
someone
get.
that stage? Because
Yep.
they won't fly someone without a pulse.
They won't fly someone without a pulse. This is one of those exceptions where they would probably have to call medical command and that sort of stuff. But this is an instance where I don't think, if you talk to an ER doc, I don't think an ER doc's going to say, no, don't transport that patient. Most of us are going to say, get them here, get them to where you think we can get ECMO started. And we've had, this was in residency, we had it was a kid. I don't remember how old he was, but was found down like in a creek, and it was winter. It was Pennsylvania, so it wasn't quite as cold as it is here. But they coded him in the field. Didn't get ROSC. He went to this local smaller hospital. They called for a helicopter. Helicopter got there, brought him to the level 1 trauma center where we were at. they stopped in the ER just to kind of mobilize everything. We got him up to the lab. We got him on ECMO, and he like made a full recovery and was like neurologically normal and stuff. And he had must have been an hour of CPR at least when everything was said and done. So these are ones that when they're cold and they're dead, like it kind of slows things down. It decreases the kind of damage to the tissues. And so this is one that if you can, it's not one that's like 20 minutes of CPR and we're done. Like this is one that you can have like neurologically meaningful recoveries from this.
So if they're flying, were you even calling for an intercept or just pouring as much diesel to them as we can?
Yeah, I mean, I would say try to call for an intercept because then they can do the other, the drugs en route too. So like the epi and all that sort of stuff. But like just kind of getting them. Yeah, yeah. So just trying to get going as fast as possible, but then also calling for the intercept, I think is going to be beneficial in this case.
That's what's the question, Winona. Is it better just to go and get there?
I think it'd probably be better.
On the side of the road.
Yeah.
In Wilson,
Right. Yeah. Yeah. Just having the medic jump in the back and just kind of do what they can do too.
And Winona doesn't have ECMO or anything like that.
No, we don't have ECMO. Lacrosse. Okay, so last I knew of, they didn't. I don't know that they would start somebody on I didn't know they have an ECMO program to start somebody on ECMO from the ED. If it was someone that was going in for like a surgery or something like that, I think they could, but I don't think Gunderson has the ability to start someone on it from the ER. But I haven't. I have a buddy I can reach out to ask him, because the last I heard, this was like maybe a year ago. They didn't have that ability. So I know for sure Mayo does, but I don't know about Gunderson.
As a general rule,
Yeah.
right now we're looking at Mayo.
Yeah, I would say Mayo. Yeah.
Well, I also know that too. They can call
Yeah.
and confirm what they want.
Yeah.
And then so when you say warm IV fluid,
Yeah.
greater than body temp, obviously.
Yeah. So were we gonna have any warmed or were we not?
Turns out those are like $600.
Okay. Probably. I don't know that it's necessarily worth it to have the warm then for how little we're going to end up using it.
Just throw it up on the dashboard.
If we're going to do that, we need an infrared thermometer so we can measure the temperature of the fluid.
Now, I actually tried ordering some through Boundary, and they've been on back order for like 3 months.
For an infrared thermometer?
Yeah. I went over to Ace and I bought a meat infrared thermometer. That didn't work. But it had a meat probe on it, so we should have done a liver check.
There you go. Right. Oh man. Okay.
But is there, let's say, right, we get a surface temp on them of 84 degrees.
Yeah.
Can you put fluid into them that's 98 degrees, or do you only want to be 10 degrees? Not that, 100 mil.
Oh, good question. Yeah, I understand. Yeah, so so the recommendation for warm fluids is greater than 40 degrees Celsius. So whatever that ends up to being Fahrenheit. So it's warmer than 98. So it's like 100 and something. So yeah, you're fine putting in something that's warmer. You don't need to kind of go in incrementally. When someone's hypothermic like this and they're in that severe range, you want to rapidly rehydrate them. So they talk about, warmed IV fluids. You can do warmed humidified air, which I don't think is necessary. You can do gastric lavage. You can do bladder irrigation. So put a big Foley in and irrigate with warm fluid. You can do bilateral chest tubes and put, warm fluid in the chest. Anyone? Chest tubes? Or like putting fluid into the peritoneum. So like it's like aggressive, warm them up quickly with that.
We put 2 lines in them and right if we have 2 warm bags.
Yep. I think that's fine. Yeah.
And then if we are doing CPR, we're trying to warm them up. Can you flow IV if we're running a Lucas on them?
Yeah. Yep. Yeah. Absolutely.
Have
Yep.
enough circulation of fluid.
Yep. Yeah. Yeah. So put in.
Even if it isn't in a heater, just ambient ambulance temperature, is that?
That should be fine with it being like in the 80s, if the temperature's that low, ambient ambulance temperature, if it's, was the bag in the truck that's sitting in there, that should be fine. Other questions before we move on to, yeah.
Hot
Yeah, so you can pack pack the hot packs in kind of the groin, axilla, kind of neck, things like that. So like packing the hot packs, I think are would be helpful.
Good
So
start.
yeah, something to at least get started with the rewarming. Do you guys have? We don't have bear huggers or things like that, right? With okay, yeah, that's right, yeah. Other questions before we move on to riveting
confused a little
consent
bit.
topics? Yes.
I thought we weren't doing rewarming with like hot packs and things.
So for frostbite and stuff like that, no. But for hypothermia, yes.
Okay,
Yeah,
thank
yeah.
you.
So for the frostbite, no. Thank you for asking that because that was probably confusing for a lot of people. Yes. So frostbite, no. We don't do the hot packs and stuff. We just do kind of the warm blankets, that sort of stuff. But for hypothermia, yes, we do the hot packs. Yes. Yeah. Yep. Exactly.
So you can even get, hypothermia in the summertime.
Right. Yep. Yeah. So it's not all about just environment. You can have it. You can get it in the summertime as well.
Our
So
trout creeks are pretty cold.
yeah. Yeah. Other questions before we start talking about consent and Minnesota statutes? Okay, this is super wordy, and so talking about consent as it pertains to minors was what we were kind of wanting to talk a little bit about. And so this is very wordy. I copied the statute and put it on here. But basically, this first part basically says any minor who is not living with a parent and is able to take care of themselves on their own. So if they're emancipated, able to care for themselves on their own, they don't need we don't need to get consent from the parents.
Now, do they have to be legally emancipated, or can it be a 15-year-old that clearly has their shit together and is
So
taking care of themselves?
by this definition, it doesn't say that they're emancipated, but the bottom part of this is who is managing personal affairs regardless of source and extent of minor's income. So if they're able to if they have a place to stay, they're able to manage their personal affairs, and they are not living with the parent or the legal guardian, and they're living by themselves, they can consent to medical or health services without a parent or guardian?
Out of curiosity, I know we're in a small town, but how do we maybe sometimes know that?
That's a great question. I don't even know how I'd know that in the ER. That's
Yeah.
one of those very
They can say they are.
difficult, right? And so how do you,
Yeah. Oh, yeah.
and how do you,
13 years old, they're in charge of their own medical records. Like,
Well, that's just it, right? At what point, right, mom and dad say, no, you aren't going. Teen says, I need help.
yeah. So that's, okay, so that's one of the other ones. So any child greater than 16 years of age, if they need help for a psychiatric treatment in the state of Minnesota, they can come in without a parent and get psychiatric treatment. There's also language, there's one of them that talks about, this is other things for minors. So if the minor has had a child at any point, or has been married at any point, then they don't need parents' consent. So if it's like a 15-year-old that had a child, they do not need parental consent anymore. They can consent to their own medical treatment in the state of Minnesota. Or if they've been married and divorced at like 15 or 16 or whatever, okay, right? So they don't need parental consent anymore. But yeah, so this one, this was a super wordy one that basically a child greater than 16 years of age can consent to to psychiatric treatment. So if they come in saying they call saying I'm suicidal, I want to kill myself, the parents say no, you're not going. If they are greater than 16 years of age, then they have the ability to say we have the ability to say, well, they can make their decisions for psychiatric care in the state of Minnesota. So we're going to take them to the yes. Right. So morally, there's a lot of things, and this is where you can, where it's like talking to the parents and getting everybody on board and trying to do all that sort of stuff. But the end of the day, the law in Minnesota is 16, then they can consent to their own psychiatric care. So yeah, if they're 15. and they're saying they're suicidal, and parents say, well, no, you're not going, then unfortunately we have to go with what the parents say. Now, if you are concerned about them, you can file a CPS report and say, hey, like, I'm worried that they are like neglectful parents and not, and so, but obviously that's more of a delayed process, right? That's not going to happen, you know, at 3 o'clock in the morning when the child's calling, or whatever. That's going to be the next business day that they would get to it. But
Well, I was gonna ask, I thought, that officers can put a 72-hour hold or a transfer hold for psych reasons on a minor, and our say can trump a parent's,
I think we've used
I
that.
thought we had, and I would think that medical
So-
professionals would have the same, but I don't know.
so yes, we have the ability. So in terms of for our like concern for, we're talking for like psych purposes or just in general?
Wasn't it like, if they're a danger to themselves and others too, that,
Yeah, I mean, that's what I would.
Yeah, so I mean the police can put them on a provisional hold and to bring them to the ER. Most of the time, that is started through police. Even in Winona, I don't think the medics don't start the holds in Winona. It's the police that do it.
Medics can.
Yeah, so I think
We
it's
had to
just
go- Because we've done it where we work with the sheriff's department on a scene to recommend them do it. We didn't have to end up going through it, the parents did send that one. But I thought there was a workaround too, because even if they say they're gonna harm themselves, you don't look at it as a psych, you just call it imminent danger,
right.
just as a superficial injury.
Right.
And just take him anyways,
Yeah.
essentially at that point.
Yeah, I mean, there's workarounds to get them there, and I mean, I think we all kind of do the right thing. It is just very the laws and stuff are very interesting and very difficult to interpret.
What about in a liability standpoint?
From
The ambulance service or the crew themselves?
for not transporting or for transporting.
Transporting underage.
I think if you are for psychiatric reasons, and so I think if you are transporting someone and you are documenting your concern about what the person said, that you're concerned that they're a danger to themselves or others, this would be one that would be helpful to have the police come and put that, like, you know, kind of provisional hold on, so you have not only your word but also what the police are saying as well and what they're concerned about. So you have two different professionals concerned.
and most calls I've been in, the officers have been involved for a lot of those.
And most of the time, I mean, emergency medicine, it's high risk, you know, you're always at risk of liability. But I think if you're doing the right thing and people can see that you're trying to do the right thing, it's going to be hard for someone to say, like, well, you shouldn't have transported that patient that said that they were suicidal and wanting to kill themselves. You should have let them stay with their parents, you know, that were not wanting them to come in and get treatment. I think there is some liability there, but I think there's always inherent liability with any of these cases. And I think my thought with these is I want to err on the side of trying to do the least harm. And I want to be able to sleep at night too, you know, so, so if like,
Probably throw it out saying,
right,
so.
yeah.
So,
So,
oh, go ahead, sorry.
no, that's okay.
I was just saying, so I mean, what about the inverse, right? The parents
Yeah.
want the 16-year-old to go because they think they're a danger to themselves, and the 16-year-old who can consent to treatment, but can they also
so
deny
yes,
it or
right,
not, or because
right.
they're 18 as they get in the truck? with
No,
them?
they can't deny it then. So at that point, then if the parents are saying that they want them to get treatment and they say no, then they can't refuse to get the treatment because they're still the minor. So they can voluntarily go to get the treatment, but they don't have the ability to refuse it. Yep. So that is a very good point that we've had to deal with quite a bit in the ER, where the 16, 17-year-olds are not wanting to be in the hospital, but the parents are saying, no, you need this. And because they are still minors, that's, what we kind of, have to do. You have to go by the parents, so.
And then, right, so we've had some cases where parents have been drunk, kid gets hurt or left in the sun. Can a parent, if a parent is drunk, right, we can visually see they're drunk, we got law enforcement involved, and they're saying, no, we don't want to transport the child, can we still transport by saying there's no one there capable of making the decision?
Yep. So that would be the next one where we get the consent. So if they are when they are needing emergent care that we deem, they would have any sort of that delay in care or treatment would be detrimental to their health, then we can make that decision to treat them and to take them to the hospital then. So, and if parent is intoxicated, they don't have the ability to understand kind of what is going on, to be able to give you that, to understand really what you're saying, and you can't wait there till they sober up. That's going to delay care. That's going to potentially have adverse outcomes on the patient. So at that point, then you would transport, and maybe try to call another parent or another guardian or another family member or someone else to try to get some other sort of consent. And if they other family member or someone else says, well, no, I don't want to transport them, well, then they need to come and be the one that takes over care of the patient. And
As long as it's not an immediate life threat.
right, exactly. As long as it's not immediate life threat. If it's anything, it's immediate life threat, that trumps it, and that's implied consent, and you
At what point
intervene.
do we make, a broken femur,
Right.
and mom and dad, they say, no, we're gonna wait for whoever to come. It's a lot different than a broken arm.
Right. Yeah. So I
Are
mean,
we just making a judgment call at that point?
that
All right,
one-
call her out, sorry, we're leaving.
that one is a judgment call. Yeah, and that's one too that I think you can call, for medical command and kind of chat with whoever's on call about it too, because those are really one-offs and very dicey. Like
Well,
every
it's not
time they
obvious,
happen.
Right? They aren't, it's not like car accident where
Right.
they're sliced up or something.
Right.
It's internal, but it's serious.
Right. Yeah, and that's something always worth an extra, set of ears and an extra person to think about and chat with you about it.
We had a case, he's talking about a call we actually had not that long ago. Is that the one with the helicopter too?
Yeah.
And the helicopter wouldn't even take a parent with the child because they were too far gone.
Oh, wow. So kind of bottom line is, when in doubt, try to contact a parent or guardian if it's, like a school scene or something like that, or something where the parent's guardian's not there. As long as it doesn't delay care and you think that would affect the outcome. So if it's something that has like a bump, something like that where, they would be refusing or not treating or something like that, or just, kind of going home, you don't necessarily need to, kind of whisk them out, and have them go to the ER. But if it's something that they need to go to the ER, it's clear and obvious to you that they need to be transported and treated, you make an attempt to contact the parent or the guardian, but don't let it delay you from getting the patient where you need to be. And you can always make those phone calls en route to that, hey, we're heading to the ER with, Joey here, and he's got, whatever, and he needs to go to the ER and get treated. So.
Schools can release a child?
I believe they contact the parents, and they have the emergency contacts, and so that would be something you can get from the school then too, and try to contact the parent. But yes, they can release if they are, if it's something emergent that you need to get them to be seen. You can take them right from the school over. Most of the time, the parents get notified and they come in to be, or at least talk to them on the phone or something. So. Okay, so the last part is just talking about the restraints. So this is kind of one of the other new sort of things is kind of discussing restraints. And so first, there's a ton of words up here, and I don't read all the words, but it's just, so the first part of kind of restraining somebody, so I want to just kind of talk about is, it's a high risk sort of a thing. It's high risk for us, treating these patients, and it's high risk for the patient too. And so the first, you want to try to do the least invasive or the least restraining sort of thing possible. So first thing that we want is just to try to verbally de-escalate the situation. So that's not going up and saying, hey, you jerk, knock it off, or whatever. You want to try to de-escalate things. And so this slide, can I just like give you guys my PowerPoint so that people can look at this stuff and read it later if they want to. But okay, so you can kind of go through this and kind of look at some of these verbal de-escalation techniques. They have whole classes on how to verbally de-escalate people, which there's a little bit of, there's some benefit to it. I think there's some good things that you can kind of learn from how to kind of talk to somebody that is very agitated in a way that will not provoke them and make them, kind of want to come at you. And so everyone has their own sort of way that they kind of, do things, but, a couple of things, just, kind of maintaining personal space, respect their space as much as possible. Don't like egg them on, establish just kind of, verbal contact, just talk to them in a calm, simple way. You don't want to be using, big words or trying to, make things, speak in long, drawn-out sentences. Just kind of, clear, simple, quick, concise things. Kind of trying to help, like, reflect back their, like, concerns or their feelings, and just kind of listen to them. Like, wow, this would be a really frustrating situation. And sometimes, like, little things like that are enough to feel like, oh, okay, maybe this guy's not a jerk. Maybe, this person does kind of understand we're in a tough spot. You can agree with things that are true, like, yeah, the world frickin' sucks right now, or something like that, like whatever, like, kind of agree with things that are, you can, but, you don't have to agree with things that are clearly wrong, like, so just, and then just setting clear, like, limits, with, hey, I understand you're in a tough spot, but, like, you will not, touch me or my staff, or you will not, like, spit or yell, or, things like that. You will not, like, curse at, me. So setting down, like, a clear boundary is acceptable, and starting with that verbal of, like, no, this will not be accepted or tolerated, is kind of important to, to start with that. And then, once you kind of make that decision that restraints are needed because the following reasons. One, you're worried that the patient is going to hurt themselves, so if they have, something where they're trying to, like, bang their head into something, or, like, trying to hurt themselves, if they're trying to hurt any one of us, if they are significantly damaging any of the, property, so if they're, like, kind of tearing the back of the ambulance apart, those are all accepted or very acceptable reasons to put somebody into restraints. And so we have the soft Velcro restraints that we have on the ambulance. Whenever you have an escalated patient that is very agitated, get the police involved as soon as possible. So if it's on scene, don't get them into the back of the truck, like, get the police involved. Oh, perfect. So you want to get the police involved as soon as possible. The more people there, the better. The recommendations that they have are, 5 people to be able to restrain somebody appropriately. So you want one person on each limb, and then one person that is, like, the director or, like, the team captain that is like talking to the patient and also, like, dictating what is going on. And so with the restraints, you want to, kind of restrain them around the wrists and the ankles and tie them down to a secure point on the stretcher. A lot of times they'll spit too, and so you can put a mask on for, like, a spit mask. And like I said, having police there whenever possible. If the police can put them in, obviously handcuffs and things like that, and, kind of keep them restrained as far as that goes as well too. So just having the police there is very, very helpful. Always restrain somebody supine, so laying on their back, never face down. That's one of those very important ones where if someone is restrained face down, they're at higher risk. Yes. So if they're restrained face down, there's higher risk of the positional asphyxia. So it can cut off their airway, and they won't be able to breathe. And so they always need to be face up. Now, if something goes down and you need to like kind of take the person down, obviously, if you can't always land with them on their back. So sometimes you're going to land with them on the ground face down, but then whenever possible, you get them face up as quickly as you and safely as you can. Once we are all kind of safe, you want to try to get them up onto their back. And so, so that's kind of the initial with. Does anyone have any questions about when to apply them? Some of the benefits, some of the concerns.
The gray area.
Yeah.
So we're at a house, patients all combative, not wanting to go. They agree, we get them in a truck, and all of a sudden they decide they don't want to be there anymore.
Right.
But we haven't left.
Yeah. That's where I would get so if it is someone that doesn't have the ability to refuse, if it's someone that we deem like absolutely has to go, they're intoxicated, they can't make their own decisions or whatever, that's when, if the police are still on scene or close, I would just kind of call for them to come back and help, because you want to try to get as many people there as possible. A lot of times just that like kind of show of force and having people there is helpful to be able to de-escalate. But then, I think you went to get the restraints when I mentioned this, but the recommendations that to do it safely is to have 5 people do it, which I know is kind of crazy when you're coming in in an ambulance, you don't have 5 people, but if you can get police there to kind of help as well. Ideally you'd want one person on each limb, and then one person that's like the team leader that's talking to the patient, explaining to them what's happening, explaining to them why it's happening, and kind of going through and making sure that everybody is like securing, getting their limbs secured and everything.
The time that Evan and I were on a call together, that he used cravats. It was on I think an older confused gentleman who was
Sure.
trying to grab me.
Yep. Yeah.
So it's not always that they're going to be combative.
Yep.
So we didn't have to put ankle restraints on.
Right.
It was just
Yeah.
just his wrists. And
Yeah.
It was fine. You walk him through it. And
Yeah. That's a good one too.
It was mainly okay. He was more confused than anything.
Yeah.
Like, hey, you can't grab people.
Right.
Situation. So that would be the other
Yeah.
time I think that this would be appropriate.
Right, and that's great too that you did the verbal, too. You said like, hey, you can't grab people. You need to keep your hands down. And so probably with the dementia, it's gonna not register or be there and stuff. But at least establishing that verbal, that you tried to do that first.
When you can do a lot of shoulder straps on our cots.
Yeah.
Sure.
Those
Yep.
new cots with those shoulder straps, you can do an awful lot with.
Yep. Yeah.
And then they don't feel like they're getting restrained
Yeah.
right away either. Then they feel like it's just a seatbelt.
Yeah.
What about patients who are seizing?
So you don't necessarily want to restrain seizing patients. You want to try to just clear things as much as you can, try to pad as much as you can, because if you restrain as they're like actively seizing, that can kind of cause injury.
Do you remember, what about a postictal patient who
Okay.
gets that
Yes.
wildness,
Yep.
but then reseizes?
Yes. So the postictal patient, I mean, those are that's a hard one, because you try to restrain them, and if they go right back into seizing again, you probably won't even be getting done restraining them before they, kind of seize again.
I think in that instance, using 3 bodies to restrain.
Yeah.
And then when he seized, we were able to like release and
I just wrapped a sheet around him
Yeah.
on
Okay.
the cot,
Yeah.
tied him down with a sheet.
Yeah. And then being able to remove so that you don't cause any
It
other
wasn't
injuries.
super violent.
Okay. Yeah.
But
Yeah.
take it out if need be, but
Yeah. There's a lot of those that are just very, when they're postictal, very violent.
that was rough.
It's unfortunate. Yeah.
If you are at a scene and an officer does put handcuffs on, be right with it.
Absolutely, yeah, 100%. If there is police officers, great, kind of helping keep everybody safe. If they do put the cuffs on, a lot of protocols have that they either ride with or ride right behind. I say I would prefer to have them ride in the back of the ambulance with you, because if it hits the fan and something's happening and they're in handcuffs, you need them out right away. Like or if something medical happens and you need to like intervene, you want to get them out right away. Or if things escalate even more, you want to have that extra person in the back of the ambulance. So I agree 100%. I would say, they're coming in the ambulance with me. I'm not going to sit there without having the officer in there with me.
I don't think an officer would object.
Yeah. I mean, I don't know the officers down here, but I know the ones in Winona don't. They're very they don't object to that when they say like, hey, can you ride in the ambulance with us? They're fine with that. So.
County guys here are good. City is.
Oh my gosh, arrest him.
He's also one of our cops.
Oh, nice. All right, cool.
A city.
So, some of the complications we talked about, obviously the positional asphyxia. So if anyone's, if they're prone, that's one of the times that, they're a lot more, concerned for airway. But even if they're kind of sitting up and we have things, kind of close to their neck or things like that, just always be concerned reassessing their airway. That'll become with the documentation, but you want to reassess frequently. When someone goes in restraints, it's a high risk sort of a thing for them, as well. And so you want to make sure that you're reassessing their airway. So, I mean, most of the time if they're calmed down, you're like, good, finally, I like a little bit of peace, but you want to make sure that their airway is still patent. So you want to be talking to them and making sure that they're still able to talk and breathe and everything. You want to reassess circulation. So when you have it on their wrists and their ankles, you want to make sure that they have pulses still. Make sure they have good capillary refill. So squeeze their finger bed and it should kind of refill within 2 seconds. Make sure that they can feel you touching your hand. Make sure that they can wiggle their fingers and wiggle their toes and everything. So there's no like circulation injury. And then this is another one too. So if they're like really in their restraints and still like fighting and like going crazy and like not calming down, they're at higher risk for rhabdomyolysis, which is basically breakdown of muscle tissue. And so for a ride from here to Winona, if someone's just going crazy, that's high risk for them to develop kidney failure and liver failure, end up needing to be on dialysis. Sometimes can even lead to cardiovascular collapse, and they can code. So if they're restrained and they're still just going crazy, that's another instance to think about calling paramedics for intercept to give some sedation, so chemical sedation. So at that point they can do medications to sort of calm them down so that they're not going crazy.
They would do that IM, right?
Yep. Yeah. So IM is preferably because you don't want to get too close to try to start an IV with that. You just give them a blow dart. Yeah. So. Yeah. And then documentation. So again, documenting first the reason, so why you restrain the person. They were a threat to themselves because X, Y, Z. They were a threat to me and the staff because X, Y, or Z. They were destroying the back of the ambulance, and this is what they did. So documenting one of those three, reasons, or documenting that they were, and then documenting what you tried to do prior. You say, I talked to them, I explained to them these things, we set up these, whatever, blah, 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 and they still were refusing. We tried to get, family involved, other people, no one, was able to. Police were trying to help as well, blah, blah. So documenting all of the things that you tried to justify the restraints, and then document to the frequent, reassessments. So documenting, the airway. So, in the ER, it's like every 5 or 10 minutes or something crazy where they have to document, the reevaluations or reassessments. So documenting the airway, documenting the CMS and the general exam, how they're doing and everything. So, charts where you're transporting someone that's restrained are going to be very big charts that are very crummy to write, but are going to be important ones because those are high risk ones for like litigation and stuff like that too. Because that is agitated and screaming at a healthcare professional has a lawyer on speed dial and is going to sue everybody. So, okay. That's it.
On the handcuffs, there's a secondary lock, there's a double lock, so handcuffs will ratchet tighter and tighter and tighter unless you activate that double lock, and then that freezes it where it can't get any tighter.
Okay.
It should be super automatic for any cop that cuffs somebody to double lock them, and check them for spacing and tightness.
Okay.
If you guys if you have a patient with cuffs on and you notice they're ratcheting, clicking down tighter, you wanna talk to the cop and just ask them to double lock them. You may have to loosen them and put it back on.
That's good to know. Thank you.
So like in the movies, you really can't like pick lock them, cause there's two locks.
It's harder, you can, but it's not as easy. Super hard. Well, a lot of times when they do that, they're in front.
Right, yeah.
That's why you have to do that.
Indiana Jones, he can get out of that.
Doc, we had a patient the other night that was do not resuscitate, whatever, whole paperwork was signed back in 2018.
Mm-hmm.
We're on our way to La Crosse, because that's where they wanted to go. And between Houston and Oka, she actually coded on us.
Mm-hmm.
So we didn't know if the machine was just screwing up or whatever. I mean, we had no breath.
Yeah.
Couldn't feel balls. We respectively put the defib on just to verify.
Yeah.
Apparently the patches were too damn cold because she took another breath and then she came back. We delivered her to La Crosse and they look at us like, you did what? Well, we just wanted to verify, you know.
Yeah.
Everything, and as of today, or last week actually, she's back at the nursing home, back in her daily routine of not doing much, but it's one of those, should we not have done that? I mean, it told us to shock.
Yeah.
Don't worry, I shut it off.
So you're saying, just to clarify, you didn't shock, just the coldness of the pads?
Just the coldness of the pad brought her back.
Was your magic touch?
Oh,
Did you-
it was-
Did you give her a precordial thump? Like, did you punch her in the chest when you did put the pads on? Or okay, because there is like a precordial thump. If you like punch somebody in the chest, it could get them out of like a ventricular arrhythmia. If someone arrests right in front of you, yeah, if someone arrests right in front of you, that's it. Yeah, depending on.
I've kind of seen that in shows sometimes too. It's like, okay.
Yep. So you do that as you're starting the CPR. You can do that. So.
You ever done that?
Yeah, I did. I have a funny story about that one. We can talk about it later. But but yeah. So it is. It didn't work when I did it. But anyway, so if they are a DNR and they have the paperwork for it, I mean,
we just
you
wanted to
didn't.
verify, you know, because
It's not. You didn't do anything wrong.
time or don't you?
Yeah, you didn't do anything wrong. Like you didn't shock, you didn't do CPR, so you didn't do anything wrong. I can't tell you, to not.
It was just kind of.
That is pretty crazy.
Weird
Yeah,
as could be.
Yeah.
I mean, we get down there and they said, "Is this normal for her?" Oh, we live with her every day. How do you know?
right.
So,
Yeah,
Did she see the light and stuff?
Yeah, she was non-responsive.
I mean, after, does she have a story now?
it's just
Yeah.
yeah. That would. I don't. I mean, I don't think you did anything wrong there. I think that was fine as long as you didn't do CPR and shock her. So, but it's an interesting story.
But then you said that she was just constipated, so what?
Yeah, so, okay, so I also work at the nursing home too, right?
Yeah.
So I looked up, I was there Saturday night, and I looked up the readmission note and the report that was charted from the nurse, on her hospital stay, and it said admitting diagnosis, constipation. Vasovagal?
Yeah, I mean, maybe that's, you know, if we can't find anything in our workup, we just find something that is true and put that as a diagnosis, you know? So, I mean, like, you know, came in and, you know, she was constipated. Yeah, that's true. That's a diagnosis. So we'll put that on there. Oh, man.
Huh. But yeah.
I don't know, that was weird.
Stop floating around now and.
What is the hospitals doing with COVID cases now? Are they still, you know, we had one the other night,
Yeah.
and we took them down there, they were just masked, they weren't gowned, they,
Yeah.
you know.
So unless we're doing like aerosolizing procedures or things like that, we're just doing like kind of masks, like surgical masks. So
Surgical mask or N95?
just a surgical mask. If we're doing aerosolizing procedures, so like nebulizers, intubation, you know, things like that, then we would, or BiPAP, CPAP, then we would put on like the full, you know, kind of N95, the goggles, the gown, gloves, that sort of stuff.
Up here the other night, they were in masks, everybody had gowns on.
That's because she
Well,
was in
that's good
COVID.
shepherd's protocol.
Yeah.
Yep, I understand.
That's,
So what's our protocol for our rate?
Yeah.
Yeah, what do we do?
Well, typically, well, like when Lynn was still here, we were mirroring what the nursing home was doing. So COVID patient, we would gown, N95 and face shield.
But nothing we're doing other than CPAP now would be an aerosolizing procedure.
No, nebulizer.
nebulizer
Or
and
not,
CPAP, yeah.
sure.
So,
But-
you want us, well, a nebulizer would be a treatment for CPAP or COVID.
Yeah, I mean, if they're short of breath,
Symptomatic.
yeah, if they're short of breath, I mean, we've been seeing a lot of COVID patients that are just like fatigue and diarrhea,
Yeah.
and so most of them are not getting.
When we get COVID patients up from the ER, the protocol upstairs is still full isolation.
Oh,
So,
Yeah, we don't
I know, and it's hard because patients are downstairs with family members. and they're
Yeah.
just masking.
yeah,
And they come upstairs and they have isolation and masks and
Yeah.
gown and, you know, there's, you know, this
You're talking about in the
huge
unit?
thing. And they get mad at us
If we're
because
doing
we're like,
generic
well,
CPAP, then I would say
you know,
N95. If
so
not,
it's-
no, because it's just dropped.
we need to be the good guy every once in a while, you know, let the family in there and do all that
But-
sort of stuff.
so
I know,
what I
I know.
say is, Winona House policy is this.
Yeah.
You do what you need to do.
Right.
That's what I say.
Yeah.
As an employee, I have to follow the rules. Do I want to? No. But but as a family member, I probably do the same thing.
Yeah. Right.
COVID's not new, it's not going away.
Right.
So what are we supposed to do?
Alright, when you're in the exam room with them, and you're not doing a neb, and you're not doing an
It's
aerosolizing
just regular
treatment,
mask.
I just have a mask.
just
Okay.
regular surgical.
That's-
Regular surgical
Should
mask. That's
that-
what I do.
Should that be our protocol?
I think that's reasonable as long as everybody is comfortable
So
with
if
that.
we're uncomfortable, we can wear 95.
You can always wear more. Absolutely. Yep. I
The only problem is if the nursing home's wearing gowns, why aren't we wearing?
They're only
gowns?
wearing gowns in the room.
So-
They're also
but
interacting
we're
with
also in
multiple
the room.
patients. Right, they're going from room to room to room, I don't
I
think.
understand that, yeah.
So, but the nursing home doesn't control our protocol.
Right.
So,
I'm just asking.
Mhm.
yeah, no, it's,
It's good discussion.
I see
Yeah.
what you're saying though, Paul. I mean, if they're going into a patient's room for 5 minutes and they're doing full PPE, why wouldn't we do full PPE for 25 minutes?
but is
None
it
of
for
what they're
them?
doing is creating aerosolization, which is how it's transmitted.
Right.
So,
But they are also saying that the nursing home going by the Department of Health or the CDC or whatever, a significant exposure is 15 minutes.
Still?
Yeah, so
Okay.
granted, our transport's gonna be longer
Yeah.
than 15 minutes.
Yeah. Because I'm thinking with like how we do things in the ER, and even with like transports from WAS are not that long, but if it is greater than 15 minutes, then probably should have full PPE for the transports from here up there, because that is a longer. I mean, you're sitting in the back of the box with them.
confined space.
All they'd have
Yeah.
to do is cough once.
Yeah. Yeah.
Could always have them put on a mask too if they aren't capable of putting on a mask.
Yeah, I mean we have everybody put on a mask when they have COVID, unless they're, we have BiPAP or something on them. But in the, if they're just kind of sitting there and their oxygen levels are fine and stuff, we just put a mask on them. Even if we have like a nasal cannula on them, we just put a mask on them too. So to kind of help protect everybody else. So that's totally acceptable. But that, they put the mask on and then they still do have the whole, full PPE protocol as well. But yeah, for the
Is it lessening up the severity of it?
Oh yeah, yeah. So I mean, they're most of the time, and it's not as much like the respiratory, like where they get like super sick with like the respiratory stuff. Most of the time, when we're admitting patients, and you probably answer this better than I can, it's more for like the general fatigue and just feeling really crummy, and they have COVID, it's causing them to feel really crummy, or
The ones that we've had, no coughing,
yeah,
it's just, the fatigue.
yeah, and it's not those like cute, like nasty respiratory infiltrates and just ARDS and stuff. Yeah.
So
Yeah.
do you think this will become as benign as influenza eventually?
Yeah, so I think it's going to eventually be like influenza, where like certain people are still going to die from it, like, because certain people still die from the flu, exactly. But I think it's probably going to just end up being similar to that, where it's another respiratory virus that we see, in the cold and flu season, that will just be treated like influenza. So.
Do you think influenza started out like that?
Yeah. I mean, what was it, 1918, with like with that pandemic, with the last pandemic, it was influenza, and so that's kind of how this all started. So, yeah.
Alright, so where we at now?
We're just, where are we?
I
Are we
think we
maxed?
better do PPE.
Yeah, I think with
transport.
the long transport times, I wasn't taking that into consideration. So
is that
full
for
PP.
confirmed cases, not just
Confirm.
suspected?
Yeah. So for confirmed cases.
If it's, you suspect it may be just a surgical mask.
So the N95 shield and gown,
Mhm.